Good morning, everyone. I would like to start by thanking the organizers of this meeting for the opportunity to participate in this forum. My name is Franz Zenker, and I am privileged to work both clinically and in research at the Barajas Clinic, an otolaryngology center in the Canary Islands, Spain. The project I am presenting today focuses on a group of patients with sensorineural hearing loss whom we have had the opportunity to follow over an extended period, in some cases for more than 30 years. Thank you for your attention, and I hope you find this presentation useful and engaging. I'd like to take a moment to introduce the institution where I work. Barajas Clinic, with over 100 years of history, began in Madrid, Spain, in 1908 before relocating to Tenerife, at the Canary Islands, where it continues to operate today. Over the years, it has accumulated a rich archive of medical histories. Originally stored in physical files, this clinical information was not efficiently utilized due to its paper-based nature. Today, with the advent of digitalization and the ability to manage large datasets, we can make valuable use of this information. This digital shift has made it much easier to integrate a longitudinal perspective into the care we provide to our patients. The Framingham Heart Study is an exemplary longitudinal study whose primary goal has been to identify risk factors contributing to the development of cardiovascular diseases. Since its inception in 1948, it has focused on understanding how lifestyle habits, genetic predispositions, and environmental factors impact cardiovascular health. The study has followed over 15,000 individuals for more than 70 years and is now examining a third generation, many of whom are grandchildren of the original participants. Thanks to its findings, the approach to cardiovascular health shifted from a reactive one, where treatment only began after disease onset, to a proactive approach. This new focus identifies risk factors such as hypertension, high cholesterol, smoking, obesity, diabetes, and lack of exercise, emphasizing prevention. The Framingham study included hearing assessment from 1978 onwards. A total of 2,293 participants were involved, with tests repeated every 6 years. The study established a strong correlation between age and hearing thresholds. For the first time, the well-known presbycusis progression curves for different age groups were defined. As shown in the graph, hearing thresholds worsen from age 60 onwards, particularly at higher frequencies. Significant differences between men and women were observed. Additionally, the study linked cardiovascular risk factors with an increased risk of hearing loss. The Framingham study was a cross-sectional study, as participants were selected by age and studied simultaneously. In 1995, the first results of a strictly longitudinal study were published. This Baltimore study followed the same subjects over time, spanning a period of 36 years. One of the key findings was that the rate of annual hearing loss varies by gender and frequency. Men experience hearing loss more rapidly, especially at higher frequencies, and this loss becomes more pronounced after age 50, as shown in the graphs. In women, hearing loss is more gradual and continuous over time. This highlights the importance of considering gender when evaluating hearing loss, as men appear more vulnerable with aging. There was also significant individual variability, meaning not all patients experience hearing loss at the same rate. The first step in the study I am presenting today was to establish a biomarker that would allow us to measure the progression of hearing loss over time. Until then, we evaluated changes visually, comparing audiograms year by year, but without an indicator to show us whether the variation was significant or if hearing deterioration was occurring more rapidly than expected. This was one of the reasons we introduced a biomarker into our clinical records to provide a numerical quantification of hearing loss progression. We defined annual hearing loss as the annual reduction in decibels observed at each frequency. We developed a model prior to data analysis to represent annual hearing loss. This model is represented by the following equation. On the left, the first term in the equation refers to the expected hearing loss based on the patient's age and gender, a value derived from ISO 7029 standards. The second term in the formula represents hearing loss due to cochlear pathology associated with individual risk factors that may cause this value to increase. The variable X represents known risk factors such as noise exposure, diabetes, hypertension, smoking, and the patient's lifestyle. Each of these factors carries a weight in the formula, represented by the coefficient beta. The term t raised to the power of alpha indicates that hearing loss does not progress linearly over time. The last term in the equation, represented by the letter e, corresponds to the error. This term encompasses factors not explained by the model, such as individual variations or measurement errors that cannot be directly attributed to the included variables. In this slide, we present the statistical method based on linear regression that we used to calculate annual hearing loss in decibels. On the left, the table shows an example of thresholds for the 1 kHz frequency obtained from a patient studied between 2002 and 2024. Next, we see the months between the first and last audiometry, with the subject's age at the time of each test shown on the right. In the center of the slide, we can see a trend line fitted to the data, along with a confidence interval that reflects the precision of our estimates. This model allows us to calculate annual hearing loss, which in this case results in a slope of 0.10 dB per month, equivalent to 1.22 dB per year. The fit measures show an R value of 0.97, indicating a very strong positive correlation between months and hearing thresholds. The R-squared of 0.94 suggests that this function explains 94% of the observed variability. In this slide, we present the results of applying linear regression to each audiogram frequency. On the left, you can see the regression lines for each frequency. On the right, we display the reconstructed data in a format similar to an audiogram, detailing the annual decibel loss for each frequency. This annual hearing loss audiogram, or chronoaudiogram, provides a simple and visual means to identify the frequencies that have accumulated a higher rate of loss over time. In this case, we observe that this patient has experienced a higher rate of loss in the high frequencies, while in the mid and low frequencies, the annual loss is around 1 decibel per year. Once we established the individual procedure for calculating annual hearing loss, we generated chronoaudiograms for the 1,200 subjects initially included in this study. Patients with conductive or neurological components were excluded. We ultimately analyzed 2,345 audiograms from 418 ears. On the left side of the slide, you can see the average annual hearing loss for each frequency. The solid line reflects our study's data, while the dashed line corresponds to the 2005 study by Lee. In our case, annual hearing loss ranged from 0.8 dB at low frequencies to 1.49 dB at high frequencies. The average annual hearing loss across all frequencies was 1.43 dB per year. When reviewing the literature, as shown in the table on the right, annual hearing loss values range from 0.75 dB to 3 dB per year. This variability arises from the types of hearing loss included in each study, particularly whether they were pure sensory neural losses or if mixed and conductive losses were included. For example, in Wattermore's work, the values tend to be higher as it included all types of hearing loss. In contrast, Davis included only subjects with presbycusis, resulting in lower rates. In conclusion, the results of our study indicate that annual hearing loss is moderate and comparable to previous studies, with variations depending on the subject profile in each investigation. In the following slides, I will present some clinical applications of this biomarker that we have recently started using. The first and most evident application is patient monitoring. Here's a quick story. I recently came across a LinkedIn post, that place where everyone seems to be an expert. A user posted about a 34-year-old patient with fluctuating audiograms, and, as expected, each reply had its own theory. The first comment suggested it could be auditory neuropathy, the second blamed otosclerosis, the third pointed to medications. But when someone mentioned empathy and psychological factors, you can't help but think, oh boy, this is getting out of hand. The last comment, and my personal favorite, simply says, Socorro Deus. Before jumping in to interpret these audiograms, we should first ask ourselves just how reliable those tests were. It's tempting to draw conclusions from one or more audiograms without any indicator of reliability. This isn't what we do with other standard tests in clinical practice, such as evoked potentials or otoacoustic emissions, which always include a reliability indicator to aid interpretation. In this slide, I present an easy-to-obtain reliability indicator based on a test-retest comparison between two audiograms. This indicator is calculated using the formula shown here, which is based on a multinomial distribution. We calculate the probability that two audiograms are significantly different. This model assumes that differences observed between two audiograms taken within a short period follow a normal distribution. In other words, it's more likely that, upon repeating the audiogram, we find small differences of 5 or 10 dB rather than larger differences of over 20 dB. Let's see how this is calculated with an example. In panel A, on the left side of the slide, we see the overlay of the air conduction results from 4 audiograms of a patient, taken over a period of 1 month and 27 days. In panel B, with a 57-day interval for the left ear, we obtain a probability value indicating significant differences between the two tests. We observe differences of 15 and 20 dB in the lower frequencies. These differences cannot be attributed to random test variation and should be interpreted clinically. The first step is to repeat the test after a few days. In panels C and D, we see the results obtained a few days later. As we now observe, the probability values are not significant, indicating no differences between the audiograms. In our view, it is more sensible to repeat the audiogram as many times as necessary rather than interpret fluctuations that may be measurement errors from either our side or the patient's. The next step was to determine the point at which changes in the audiogram can be observed and attributed to the passage of time. In this slide, we see a scatter plot showing the progression of hearing loss in the study. On the vertical axis, we have the rate of hearing loss in decibels per year, and on the horizontal axis, the study duration in months. On the left side of the graph, there is high data dispersion, indicating significant variability likely due to fluctuations, as noted in previous slides. In the early months, we observe negative values, suggesting improvements in hearing, an unlikely outcome and a reflection of these fluctuations. As the study duration increases, this variability decreases, and after 50 to 100 months, most patients show a positive rate of hearing loss. This graph suggests that assessing the annual rate of hearing loss on an individual basis requires a minimum period and number of measurements to obtain a clinically interpretable value. In this graph, we present a model of annual hearing loss as a function of study duration. In the upper right, we see the equation that describes the relationship between annual loss and study time. This equation indicates that as study duration increases, we can detect smaller changes in the rate of hearing loss. The constant in the equation refers to the 5 decibel increments typically used in most audiometric procedures. In other words, in the hypothetical case where a patient loses 1 decibel per year, we would need at least 5 years of follow-up to detect any change. As we move to the right on the graph, study duration increases, allowing us to detect progressively smaller changes. At 10 years, we could detect changes of 0.5 decibels per year, at 15 years, 0.33, at 20 years, 0.25, and so on. Projecting the average annual hearing loss of 1.43 decibels, obtained from our sensorineural hearing loss control group, we find that it would take approximately 3.5 years, on average, for the accumulated loss to reach 5 dB. In other words, in patients with sensorineural hearing loss, changes in the audiogram due to the natural progression of the loss cannot be detected in periods shorter than 3.5 years. The next obvious clinical application is the ability to determine when a significant threshold shift has occurred. Let's go through an example. These 2 audiograms were obtained from the same patient, 2 years apart. I have a question for you. Would you consider there to be a significant threshold shift between these 2 audiograms? At some frequencies, the differences reach 15 decibels. Are these differences significant? Is that a lot? Or not much? Here, you can see the chronoaudiogram we obtained for this patient. We observe that these differences in the right ear, ranging from 10 to 15 decibels over 2 years, correspond to an annual hearing loss rate of approximately 6 decibels per year. This rate exceeds the average of 1.43 decibels per year found in our cochlear hearing loss control group. The reason is that this is not a case of cochlear hearing loss. As you can see on the MRI, there is an acoustic neuroma in the right cerebellopontine angle, measuring approximately 14 mm. This also affects the brainstem auditory evoked potentials, which show interaural differences in wave 5 above the expected range and an elongated 1 to 5 interval in the right ear. This case highlights how calculating the annual hearing loss rate reflects the progression of the neuroma. This analysis, along with other tests and the patient's clinical history, allows us to better interpret differences in hearing thresholds, providing a more precise view of how the tumor is impacting the patient's auditory function over time. The next application is to use this longitudinal perspective to establish phenotypes that help us better understand the progression and etiology of hearing loss. For decades, researchers have sought to define audiometric phenotypes. Some classifications have been based on pathophysiological studies. A notable example is the work of Harold Schucknecht, who conducted histopathological studies using temporal bone samples and developed a classification for types of presbycusis. Schucknecht identified for phenotypes, sensory, neural, metabolic, and cochlear conductive, based primarily on observations of the deterioration of hair cells, the stria vascularis, and the auditory nervous system. More recently, Judy Dubnow, using animal models, has identified age-related hearing loss patterns. Dubnow established 3 profiles to classify hearing loss as metabolic, sensory, or mixed. Recent work has aimed to identify phenotypes through the analysis of large audiogram databases. An example is Parthasarathy's research, which identified hearing loss patterns from large datasets. These models enabled grouping audiograms into clusters that represent different hearing loss phenotypes, based on the shape and severity of the audiograms. At the recent International Society of Audiology conference held in Paris, I had the opportunity to learn about the work of Gerard Encinas, a researcher at the Copenhagen Hearing and Balance Center and a lecturer in the new audiology program at the Barcelona University of Vic. Gerard has conducted a large-scale study, analyzing clinical data from over 96,000 patients and nearly 300,000 audiograms collected over 27 years at Denmark's Rigshospitalet. Using principal component analysis, Gerard has identified distinct auditory phenotypes that reflect patterns of hearing loss similar to those proposed by Judy Dubnow. Here's a photo of the 3 of us in Paris just a few months ago. Based on our data, we analyzed the rate of hearing loss according to audiogram phenotype. We classified the losses into these 6 categories. Ultimately, we focused on these 4 categories, as only these had a sufficient number of patients. The sloping configuration showed the highest annual hearing loss rate, remaining more consistent across frequencies. This was followed by the rising configuration. The trough-shaped profile, reflecting a valley shape, shows lower rates at the extreme frequencies, with an increase in the mid-frequencies between 2 and 4 kHz. Finally, the flat configuration presents a fairly uniform hearing loss, with minimal variation and a more moderate annual loss rate compared to the other profiles. In general, we can conclude that phenotype influences the annual hearing loss rate. The rising and sloping configurations exhibit the highest annual hearing loss rates. These findings, like previous studies, suggest that the underlying pathology shapes the phenotype. A high percentage of hearing losses likely have a genetic origin. There is an increasing need for clinical indicators that allow us to infer potential genetic mutations. The progression of hearing loss is a distinguishing factor in the phenotype of certain non-syndromic hearing losses. As shown in this table, some genes lead to losses with minimal progression, while others cause progressive changes that may be rapid, slow, or, in some cases, stable. However, we currently lack an indicator to define what constitutes a rapid or slow loss. Let's look at an example. In this slide, I present a patient, an 18-year-old male with a congenital, bilateral, moderate sensory neural hearing loss. The patient has a twin brother with a similar hearing loss, and his parents are cousins. As you can see here on the left, there are no substantial changes in auditory sensitivity over time, indicating a stable hearing loss. This pattern, along with the family history and parental consanguinity, suggests a non-syndromic hearing loss with autosomal recessive inheritance, likely due to both parents carrying a mutation in the same recessive gene. On the right, we see the phenotype-genotype correlation based on this patient's audiograms. This analysis was conducted using the AudioGene application, a tool developed by the University of Iowa, which enables us to predict the genetic cause of hearing loss with a 68% probability. In this case, the software suggests these top 3 options as the most likely causes. In summary, this biomarker allows us to quantify and establish the rate of hearing loss, enabling us to classify the progression more concretely rather than speculatively, as we have seen in this slide. The main reason we started this study was our patients. Prospective studies have the virtue of humanizing the data. Each point on a graph represents a patient we know. Those who participated in this study have done so over long periods of time, deepening our understanding and connection. Hearing loss involves a process of psychological acceptance, in which we become companions to the patient. In this journey, it's common to hear phrases like, "What's there to hear anyway? I feel like I'm hearing much worse," or, "I think I'm going completely deaf." All these statements reflect concerns about the progression of their hearing loss, concerns that, for most patients, aren't confirmed by the clinical evidence we observe. My response to these comments used to be dismissive. Although my arguments were well-founded, I still had doubts about my reassurances. I wasn't fully confident in the reliability of the audiometries, the presence of significant threshold shifts, or whether the progression of hearing loss was faster than usual. With the study I've presented today, we've aimed to answer these questions. The knowledge gained not only benefits us clinically but also supports the patient, allowing us to offer reassurance and a message of hope. In conclusion, the development of this biomarker enables us to monitor, classify, and manage hearing loss, and in some cases, it may even help us identify the etiology of the hearing loss. Additionally, it supports the rehabilitation of our patients by providing empirical evidence of the progression of their hearing loss. Incorporating evolutionary reports into the clinical record allows us, as in other specialties, to adopt a proactive approach that keeps us one step ahead of the disease. Thank you for your attention to my presentation. I would be pleased to answer any questions if I have managed to spark your interest in this topic.